Hi friends, we are going to talk about removable partial dentures, and this session is going to be a short quick session which is the last minute revision points. So when you talk about removable partial dentures, there are a few things which are really important for us to know as far as the examination part is concerned. So we need to understand why we want to read removable partial dentures separately, because they work on a principle where the tooth as well as the tissue is involved. So it is tooth plus tissue supported partial denture. That means the biomechanics is going to be completely different. And when I say different biomechanics, what I mean is that the biomechanics of the tooth taking up the load and the tissue taking up the load is different, because the tooth is going to get displaced by less than 0.1 millimeters, whereas the tissue is going to get displaced by greater than 1 millimeter when we talk about functional loading. So that is what we need to understand, that there is a difference between the tooth and tissue. That is why we have to understand the biomechanics very carefully. Coming on to the basic part, the first level of questions which come in are from the Kennedy classification. When we talk about Kennedy classification, there are 4 classes and not 6. Do not make this mistake, right? What are the 4 classes? We very well know about it. The 5th and 6th are modifications which were made by Applegate, right? So we need to understand that when the question asks you how many classes of Kennedy classification, the answer is going to be 4 and not 6. The modification, other 2 are the modifications of Kennedy classification. And then Applegate gave you a set of rules, right? These rules govern the final classification, right? So that means it is going to give something which is called as modifications. So there are a set of 8 rules which you need to understand. The most important ones say that the most posterior edentulous space is going to determine the classification. That means when you talk about Kennedy class 4, there is going to be no modification involved in Kennedy class 4, right? Now, what an RPD consists of? A removable partial denture has got a lot of components which we are going to talk in brief, and starting with the first major component, which is called as major connector. What does a major connector do? A major connector connects one side of the arch to the other side. That is the function of a major connector, right? Now, these major connectors, the most important property of a major connector is rigidity, right? You will get an option of rigidity and comfort, aesthetics, retention. All those are not the primary properties of major connector. The primary most important property of a major connector is rigidity, right? Coming on to the maxillary major connectors, you have a lot of different maxillary major connectors. What are the very important questions which come up in maxillary major connector? What should be the distance between the border of connector to the free gingival margin? What should be that distance? The answer is 6 millimeters. This is the first important question coming up from maxillary major connectors. Now, what are the different types of maxillary major connector? We all know it. It is the first important one is the posterior palatal bar and the posterior palatal strap. Now, what is the difference? What are the indications? What are the contraindications? Which is going to be your first choice? Which is going to be your last choice? In what kind of cases? These are the type of questions which easily, most commonly pop up from the major connector section. So when you talk about the posterior palatal bar, the first important question is the shape, half oval. Very, very important for you to remember. Posterior palatal bar. Excuse me. So the posterior palatal bar is half oval in shape, right? Where do you use it? It is used in Kennedy class 3 cases. Kennedy class 3 means it is going to be a tooth supported RPD. So when you have a tooth supported RPD, you use a posterior palatal bar. It is half oval in shape. So that is what you need to remember. Posterior palatal strap is similar to the bar. It is just that the posterior palatal strap is a wider is more wide as compared to your palatal bar, right? Another important question from posterior palatal strap is called as L-beam effect, right? What do you mean by an L-beam effect? L-beam effect means that the bar is going to, if I talk about the maxilla, this is how the maxilla is. And if I have a posterior bar here, it is going to be located at this area, somewhere in the region of second premolar, not distal to it, right? And when you talk about a posterior palatal strap, it is going to cover up this entire area from the anterior to the posterior part. And here what you see is a sort of L, which is called as the L-beam effect. Now, when you have forces coming across this L-beam, a couple of forces will move into this dimension, the remaining ones will move into this dimension. So the force distribution is much better in a posterior palatal strap as compared to the posterior palatal bar. Coming on to the antero-posterior bar and antero-posterior strap. What are the major indications? Maxillary torus, right? If you have a maxillary torus right on the palatal, the antero-posterior bar or strap would be your choice. Talking about an antero-posterior strap, it is important that you have 20 by 15 millimeter space in between both the straps, the anterior and posterior, right? So it is important that you have this amount of space in between the anterior and posterior strap. Coming down to the next important type of connector, which is called as horseshoe shape. In horseshoe shape, you can have an open horseshoe or you can have a closed horseshoe. So how does a horseshoe major connector work? This is how you have a horseshoe major connector. Where do I use a horseshoe connector? When you have multiple anterior missing teeth, right? So when you have anterior missing teeth, you need a connector which is horseshoe shaped, which is called as a horseshoe connector. Now, when you talk about an open connector, this area, if I add a posterior palatal bar here, this area is going to now become a closed connector, right? So when you talk about a closed connector, it is much more sturdy as compared, much more rigid as compared to the open horseshoe. The reason being, when you talk about an open horseshoe, this is how it is going to be. And whenever there are forces being applied, this is going to flex, right? So these flexion forces are the problem in an open horseshoe type of connector. That is why we prefer a closed horseshoe. If I want that this area should not bend, what am I supposed to do? I will have to increase the bulk of material, because if I don't increase the bulk of material here, the entire area is going to get flexed. Once you increase the bulk, what happens? It is going to become uncomfortable for the patient to be used because you have excess bulk in the maxillary anterior area, right? The next one which we have is called as a complete pallet. So when you talk about a complete pallet major connector, which is the complete arch, this is used when you have periodontally compromised teeth, right? So when you have periodontally compromised teeth, we use a complete pallet, right? So it is not a very commonly used major connector, but this resembles your regular RPDs, which you make your RPDs in your graduation days. So you have those curvatures which you put around the teeth, something like this. So this is how you have a complete pallet major connector, which is going to support all the other teeth. It is going to distribute load among all other teeth. That is why it is called as a complete pallet major connector. Coming down to your mandibular major connectors, in the mandibular major connector, you have a lingual bar. Very important questions coming up from lingual bar is that you require 8 millimeter of space. Why do I require 8 millimeters? 3 millimeter from the gingival margin. This holds true for any mandibular major connector. 3 millimeters from gingival margin and 5 millimeters should be the width of the bar. That means from the free gingival margin till the floor of the mouth, what you require is at least 8 millimeters of space. So lingual bar is one of the most commonly used mandibular major connector. The next one is a lingual plate, also called as a lingual plate. Now this lingual plate or lingual plate is similar to the RPDs which you construct, which you make, making sure they're about their margins. So this Lingua Plate major connector has got two important points to be remembered. One is called as the ledging effect, and the other one is called as a step back technique. Now, what is meant by ledging effect and step back? Now, if you have a lingual plate covering onto the lingual areas, and there is a patient which has got spacing between the teeth. Now, if you have spacing between the teeth, it is sure that your lingual metal margin is going to be visible when the patient smiles. So those areas, what you are going to do is your major connector is going to come down and again down, so that when you have teeth present here and the space in this area, the connector goes down. When the connector goes down, you cannot see it. So this is what is called as a step back. Secondly, when you see the margins of your connector, they are going to lie on the teeth, right? They are going to lie on the anterior teeth. They have to be so thin that there is absolutely no ledging effect when we talk about the Lingua Plate major connector. Another important modification of a Lingua Plate is called as swing lock denture. Right? So the swing lock denture is a modification of Lingua Plate, which involves a labial bar with a small hinge. Right? This is what is called as a swing lock denture. The next one is called as a double lingual bar, which is also called as your Kennedy bar. Now, what is a Kennedy bar? A Kennedy bar is indicated only when you have open embrasures, right? So that you have support coming in because of the double lingual bar, right? What is the shape of, whenever you talk about a lingual bar, right? The shape is always half pear shape. When we talked about the posterior palatal bar, the cross-sectional shape was half oval, right? So do not get confused when the question is asking you about a lingual bar or a posterior palatal bar. This is how the cross sections differ when we talk about these two bars. The last one is called as a labial bar, and this labial bar is usually used for lingually inclined teeth. Right? When you have lingually inclined teeth, you cannot put a lingual connector. There is where you have a major connector coming out from the labial side. That is called as a labial bar. The only disadvantage of a labial bar is aesthetics. Why aesthetics? Because this labial bar is going to distort the lower lip because it is present on the labial side. So that is what you need to understand, that this is going to distort the lower lip, and that is why we do not use a labial bar very commonly. So this is majorly about the major connectors. Next, we are going to talk about minor connectors, right? So in minor connectors, you do not get a lot of questions, but what you need to understand is the major function of a minor connector. The major function is to join all parts of the RPD to the major connector, right? So that is what is the function of a minor connector. So you will require a lot of different minor connectors in your removable partial dentures, because they are going to join different parts to the major connector. Like the first one will join the clasp to the major connector. The second one joins the denture base to major connector. The third one joins indirect retainer to major connector. And the fourth one is again related to the clasp. It acts as an approach arm for Infra Bulge Clasps. Right? So this is what you need to understand, that a minor connector is going to basically connect the direct retainer to the major connector, the denture base to the major connector, the indirect retainer to the major connector. What kind of questions do appear from the chapter of minor connectors? The most important question, which is a very common question, is related to external and internal finish lines, right? So when we talk about a removable partial denture, which is like a distal extension removable partial denture, this is the situation. You have anterior teeth which are present, and these areas are going to be your saddle areas where I'm going to use my removable partial denture. So when you make a removable partial denture, just before the casting procedure, you have to place a small spacer in this area, right? And that spacer will have a small tissue stop, the way you do for your complete dentures, a wax spacer and a small tissue stop. So when you have, why do you have this wax spacer? This wax spacer is going to allow the acrylic to flow in between the meshwork, the acrylic to flow in between the entire saddle area, between the metal and the tissue. You are going to have acrylic. Obviously, for the area which is above the metal, you are also going to have acrylic, because that acrylic is going to hold the teeth. So as I've already discussed the entire procedure of a cast partial denture in the full session. I'm not going to talk about it right now because that is beyond the scope of this session. But what you understand is that when you have the metal as a junction, acrylic on top of it and acrylic on the base of it. So the junction between this base acrylic with the metal is called as internal finish line, and the acrylic which is on the outer part, that junction with the metal is called as an external finish line, right? So that what I'm talking about here is the junction between the external acrylic to the metal and the internal acrylic to the metal, right? So that is what is called as an external and internal finish line. External finish line, the angle is always less than 90 degrees, right? Whereas the internal finish line is a butt joint. Very, very important part you must remember, because this question has come up a number of times. The external finish line makes a junction which is less than 90 degrees, whereas an internal finish line makes a junction exactly at 90 degrees. That is why it is called as a butt joint. So how is an internal finish line formed? An internal finish line is formed as a result of the relief wax, right, which is placed before the casting procedure is done. Now, when you talk about the relation of the denture base to major connector, so you have seen cases where you have this as your removable partial denture, and these are the saddle areas. A few images you will see where you have the saddle area which has got something like a ladder. A couple of cases where you will see thin ladder and then you will see a complete meshwork, right? So you have different types of denture bases. So there are other denture bases wherein you have small beads which are going to hold the acrylic. Now, which area do I prefer to put a ladder? What area should I put just a bead or a nail head? Where I should have a mesh? Now, ladder and mesh, these areas are supposed to be used when you have both tooth and tissue support. Why? Because this tissue is going to get remodeled with time, with forces, and once this remodeling is done, I will have to reline or rebase my denture. So if I have to reline or rebase my denture, I require the acrylic to flow beneath the metal and above the tissue. Only then I will be able to reline. You cannot reline the metal. What I can reline is the acrylic part. So what you see here is that nail heads or beads are typically used in Kennedy class 3 or small span Kennedy class 4. But these mesh and ladder are used in Kennedy class 1 and class 2 because there is where you have a distal extension removable partial denture and you will have to repeatedly do relining and rebasing with these dentures. Right, so this is majorly the important part from removable partial denture minor connector. These are the questions. So the bands which you see here are called as longitudinal struts, right? And the ones which you see other side are called as your transverse struts, right? So this is what you have to remember. The maximum extension for maxilla is going to be till tuberosity for the minor connector in the denture base, and for mandibular, the retromolar pad. Right? So this is what is required. It should extend at least up to 2/3 of the ridge when you talk about the minor connector in maxilla or mandible. Coming on to the next important part, the rests and rest seats. Very simple concept, but a lot of questions coming up regularly from rests and rest seats. what is the primary function of a rest? Rests are part of removable partial denture, whereas the rest seats are part of the mouth. Rest seats are prepared on the tooth surface, occlusal, proximal, right? So these are the rest seats. So rest seat is not a part of RPD. Rest, yes, it is a part of RPD. The main function of a rest is to direct all forces apically, right? Preferably in the direction of the long axis. So if you are getting the entire force directed towards the long axis, that is the purpose of having a rest. Now, what are the different types of rest? You have an occlusal rest, you have an incisal rest, and you have canine rests, also called as lingual rests, right? So we will talk about the questions which come up from occlusal rest, incisal, canine rest. So when you talk about occlusal rest, the first and the foremost important question which comes here is, what is the shape? The shape is always rounded, triangular when we talk about rests. Usually, in options, you might not get this rounded triangular. So if they have only triangular, you can take triangular as your answer. But if they have an option of rounded triangular, that is going to be your first choice in that question. So the shape is rounded triangular. 1/3 to half of the mesiodistal diameter of the tooth and half of the buccolingual diameter of the tooth. This is going to be the dimensions of an occlusal rest. Angle. What angle does an occlusal rest makes with the margin of the tooth? It has to be less than 90 degrees. Supposedly this is the tooth and here is my rest. I make an obtuse angle. This obtuse angle will always lead to slippage. The prosthesis will keep on slipping. That is why the margin is always supposed to be an acute angle, right? The occlusal rest is always directed inwards. Inwards means it is going to be towards the center of the tooth, right? That is what is going to be the removable partial denture occlusal rest, right? Minimum thickness is 0.5 mm, but the thickness is 1 to 1.5 mm in the area where it crosses the marginal ridge, because you have a lot of forces in that area where you're crossing the marginal ridge. That is why you need to have more thickness. The next important question comes in from lingual rests. A lot of confusing questions is what is the shape of a lingual rest, right? Now, when you see a canine, these are usually made in maxillary canine. The questions usually asked are whether the shape is a half crescent shape, half moon shape, or is it a V shape. So we have to understand that when you see a cross-sectional view, in cross-sectional view, it is V-shaped. When you have a lingual view, it is crescent shaped or half moon shape, right? So it is very important to see what the question is asking. So if they are talking about lingual view, the answer is going to be half moon or crescent shape. If they're talking about a cross-sectional view, the answer is going to be V-shaped, right? What are the dimensions? 2.5 millimeters mesiodistally, 2 millimeters buccolingually, and 1.5 millimeters should be the depth of the lingual rest. Coming on to the incisal rest, never the first choice. It is never first choice. Why? Because they are placed in the incisors, usually the mandibular incisors. If this is how the incisor is, V-shaped rest is placed. Now this should be around 1.5 to 2 millimeters away from the proximal incisal angle. Right? 1.5 to 2 millimeters away from the proximal incisal angle is this V-shaped rest. And it is going to be 3 to 3.5 millimeters wide and 1.5 to 2 millimeters deep. So if you have an option of giving an incisal rest or a lingual rest, we will always try and give a lingual rest. Why? Because the lingual rests are going to give more axial forces. Why? Because the lingual rests are placed very close to the rotational centers of the tooth. So if they are placed very close to the rotational center of the tooth, entire force is going to get transmitted along the long axis. And that is what is the function of a rest, as we discussed, that the rest is supposed to transfer forces apically. It is supposed to act as a positive vertical stop, does not allow your removable partial denture to keep on jumping. So rests are going to give support to the removable partial denture, right? And when we talk about the stability part, we discussed the major connectors and the minor connectors. So the third most important property of any prosthesis is retention. How do we get retention in a removable partial denture? So for that you have your direct retainers and indirect retainers. Right? So every component has its own function. So when we're talking about the support, we were talking about rests. When we talk stability, it is major connector, minor connector. When we talk about retention, it is going to be direct retainers and indirect retainers. Now, direct retainers is a huge topic. There are a lot of questions which come up from direct retainers. So what you first need to understand is the major part of the classification of direct retainers. Now, direct retainers can be intracoronal or extracoronal. Intracoronal are called as attachments, and these can be precision attachments and semi-precision attachments. When you talk about extracoronal, in extracoronal you can have attachments or you can have clasps. When we talk about extracoronal clasps, you have suprabulge and infrabulge clasps. In attachments, again, you have your precision attachments and semi-precision attachments. So we are going to talk about these clasps in greater details, but what we need to understand is what do you basically mean by the term clasp assembly. So when you talk about clasp assembly, the components which are involved here are rests. You have something which is called as a retentive arm, you have something which is called as a reciprocal arm, and you have a minor connector, right? So these retentive and reciprocal arms are really important because you have to understand that when the forces are being applied, the retentive and the reciprocal arm have got their specific purposes which have to be solved when you talk about a clasp assembly. So the retentive arm, terminal part of a retentive arm is always flexible. Which contacts first? A number of times this question has come, whether the retentive arm contacts the tooth first or the reciprocal arm contacts the tooth first. So it is always the reciprocal arm which is going to contact first, because the retentive arm is going to come in, get into the height of contour, and then engage the undercut area. So we do not want that the movement when the retentive arm is going in along the tooth, it should not push the tooth onto the other direction. So you have to have a reciprocal arm which is already present there to support the excess force which is coming up when you push the retentive arm in. So the reciprocal arm always contacts first, right? What are the requirements? Retention, stability, support. We know all these three. Three more important requirements are encirclement, passivity, and reciprocation, right? So we have talked about reciprocation just now. When you talk about encirclement, a clasp should at least cover 180 degrees. That should be the encirclement, which is important. It should stay passive. The entire direct retainer, the clasp assembly, is supposed to stay passive till non-retentive forces are being applied, right? So that is what is important for you to see, that the entire prosthesis must be passive. What is the relation between the length of the clasp and flexibility? So if the length is doubled, the clasp length is doubled, the flexibility increases by 5 times. Very important question. 5-fold increase in flexibility when the length is doubled. What is the optimum ratio of width is to thickness? 2:1. To get a good flexibility, at least 2:1 has to be the thickness, right? Prothero cone theory. A lot of times this question has been asked. Now, if I talk about a tooth, this is how a molar looks, right? So what Prothero said, that if I talk about this area, which is the height of contour, the maximum bulge present on the tooth, I can consider it to be 2 cones. Every tooth is considered as 2 cones, right? And this area is going to be the height of contour. So the retentive arm should always be on the lower cone, and the reciprocal arm should be in this area, which we are going to talk about, so that as soon as the forces are being applied, the reciprocal arm acts and controls these forces in this area. Now, when we talk about different suprabulge clasps, you have already seen that there are a lot of questions coming up from suprabulge clasps, but we are not going to talk about all the concepts in detail here. But what is a suprabulge clasp, which comes from the occlusal part, right, which is called as the suprabulge. What is the bulge here? The bulge is the height of contour. So any clasp which is originating occlusal to the bulge is called as a suprabulge clasp, and any clasp which is originating inferior to the bulge is called as the infrabulge clasp. So how do you know these suprabulge clasps? Simple circlet. We have heard about this clasp so many times. The clasp which you make in your orthodontics, the C-clasp, right? The C-clasp of ortho, a clasp like this, is our simple circlet clasp. The prosthetic C-clasp is completely different from the orthodontic C-clasp. The orthodontic C-clasp is our simple circlet clasp. What are the kind of questions? Which undercut does this engage? It is always the mesio-buccal undercut. Now you remember that if you have a case where you have your teeth present and this is the distal extension, your clasp will always come like this, right? The terminal of the clasp is going to engage this area, which means it is going to engage the mesiobuccal undercut of the abutment tooth, right? So simple circulate clasp will always engage the mesiobuccal undercut. Another important question is the cross section. It is always a half round cross section. And this is going to be our clasp of choice for Kennedy class 3, right? Which is tooth supported RPD. So simple circulate clasp. Which undercut? Mesiobuccal. What shape? Half round. What is the indication? Tooth supported RPD. That is all what is required for you to learn about a simple circulate clasp. Similarly, you have a reverse circulate clasp. What is a reverse circulate clasp? A reverse circulate clasp is exactly the opposite of simple circulate. So which undercut does it engage? The distobuccal undercut. Areas where you do not have a mesiobuccal undercut, those areas you use a reverse circulate clasp. Although there are other clasps also which can be used for a distobuccal undercut, reverse circulate clasp, the major disadvantage is that it cannot be used in the areas of canines or premolars because it is going to be aesthetic failure, right? That is why we do not use reverse circulate clasp when you have a distobuccal undercut. We move on to different options like Infrabulge Clasps, like C-Clasp. So we will be talking about that in a while. So these are majorly used for distal undercuts, the distofacial, distobuccal undercuts. That is what we need to remember. Third one is called as a multiple circulate. What is a multiple circulate? It is always used. The indication of a multiple circulate clasp is periodontally compromised teeth. It is used in periodontally compromised teeth. Where are these joined? You have so many circulates and they are joined, right? That is why it is called as a multiple circulate. So are they joined in the retentive arm or you have to join them in the reciprocal arm? All these clasps in multiple circulate are joined at the reciprocal arm. If they are joined at the retentive arm, it is going to be extremely high retentive force and you will not be able to dislodge the prosthesis when trying to remove it, right? It can become a kind of a fixed prosthesis. Next is your embrasure clasp. Now, where do I use an embrasure clasp? You have a situation like this, where you have all teeth present, and this is a situation of Kennedy class 2. You have this saddle area. This is one undercut which you have involved using your clasp, the mesiobuccal undercut. What undercut do I use on the other side? I don't have an undercut here to be used. So when I make my plate, I am going to cross over the occlusal embrasure and make sure that my clasp is on the embrasure and getting retention from both the teeth exactly opposite to the saddle area. Right? So this kind of clasp is known as embrasure clasp, indicated in Kennedy class 2. If you have a modification somewhere, you can obviously incorporate different clasps there. So in a Kennedy class 2 case where you have the other side having all the teeth present, there is where we use an embrasure clasp. Ring clasp, we do not use a ring clasp much anymore. A ring clasp is indicated for tipped molar. Usually in the mandible, it is indicated for a tipped molar, right? And when you have a tipped molar, which is tipped mesially, you will usually have a mesiolingual line angle undercut. So if the question is talking about a mesiolingual line angle undercut in a molar, even if they have not used the term tipped, your answer is going to be a ring clasp. Coming on to the C-clasp. Now the C-clasp is also called as fish hook clasp or the hairpin clasp. The fish hook clasp or the hairpin clasp, what does it mean? Now you have a tooth like this, and if I give a clasp, right, what you see here is something like a hairpin bend or a fish hook. So in a C-clasp, which is the fish hook or hairpin clasp, you have both the retentive as well as the reciprocal arm on the same surface of the tooth. Right? So that is what you need to remember, that this kind of a clasp will have both the retentive and reciprocal terminals on the same surface of the tooth. The only problem here is inadequate flexibility. Now in this case, which is going to first contact the tooth surface, the retentive arm or the reciprocal arm? Obviously the retentive arm. What we read earlier was that the reciprocal arm should be there first on the opposing side. But here, since we have placed both on one side, it is obviously the retentive arm which is going to first come in contact and then the reciprocal arm. The next important clasp is called as wrought wire circumferential clasp, also called as combination clasp or a double bow clasp, right? Now what happens in this clasp? Wrought wire circumferential. So it is going to be a clasp where the retentive terminal is made with wrought wire, When would I require a wrought wire? When I have deeper undercuts. So when you have 0.010 inch undercut, you can use your cast clasps. And when the undercuts are more than that, like 0.015 to 0.020, in such cases you have to use a wrought wire, right? So you have a wrought wire clasp where the retentive terminal is made up of wrought wire. The other part is made up of the cast clasp. And so this helps in dissipation of forces, and that is what is called as a double bow clasp, or which is named as a combination clasp by Applegate. The next one here are the infra bulge clasps. Now, infra bulge clasps, they approach from the gingival side, right? And they give a type of retention which is called as push type of retention for the suprabulge clasps, and pull type of retention in the suprabulge clasps. So what you need to understand that when you have an infrabulge clasp, the infrabulge will always give you a push type of retention, whereas the suprabulge will always give you a pull type of retention because you have to pull the removable partial denture. So this is infra. This is infrabulge. So what are the different types of infrabulge clasp? So you have a T-clasp, which is like this. You have a modified T-clasp. You have a Y-clasp, and you have an I-bar, right? These are different bars. So when you talk about a modified T, when you talk about a T here, one is going to be your reciprocal arm, one is going to be your retentive arm, and this is going to be the approach arm, right? Which you remember that this is a part of your minor connector. In the modified T, the reciprocal arm is not there, so you just have a retentive arm. Y-clasp is used when you have height of contour which is higher. So this is just a modification of the T. This was T and this is Y. It is just a modification. In I-bar, which was given by Kratochvil, we have no retentive or reciprocal terminals which have been kept on the Y-bar, I-bar. So most commonly used infrabulge retention is by the I-bar, which we are going to read also the in the infrabulge part. So next we are going to talk about the indirect retainers. So we are going to talk about the indirect retainers. So the function of an indirect retainer is to help the direct retainer in retention, right, as the name suggests. Now these are majorly used for distal extension RPDs. Mostly the indirect retainers are incorporated in your distal extension RPDs. Now what it basically does is it prevents any kind of rotational movement of the RPD, right? And there is a concept of fulcrum lines which are involved when you study about the indirect retainers. So if you have a situation like this and you have your remaining teeth present here, these are the distal extension areas. Now this is going to be your terminal axis, right? Which is going to be the fulcrum line in between both the abutment teeth. Now you place an indirect retainer somewhere here exactly perpendicular to the fulcrum line. This is called as an indirect retainer, right? So what basically is an indirect retainer? It is an auxiliary rest. We have read about different rests. So this is an extra rest, an auxiliary rest which is going to act like an indirect retainer. Sometimes your Lingua Plate major connector also acts as an indirect retainer. Now, to understand this concept, we need to understand the forces which are applied on a removable partial denture. One is the movement towards the tooth, movement towards the tissue, and the third one is the buccolingual movement or the horizontal movement, right? So this is what affects the stability, right? This is what affects the stability. As far as the movements towards the tooth is concerned, you have direct retainers to combat that. Towards the tissue, you have rests to combat that. And when you talk about the buccolingual movement or the horizontal movement, you have your indirect retainers, you have your denture base, you have your major connectors, you have your flanges. All these act so as to reduce the action of the buccolingual forces to decrease the amount of horizontal movement. Now, what basically do you mean by a fulcrum line? A fulcrum line joins the most posterior abutments, right? So the most posterior abutments are joined by this fulcrum line, and the denture rotates around this line, which is called as the axis of rotation, right? So you basically have two parts here. One is the retentive and the other is the stabilizing part, right, which acts against the masticatory forces, and the retentive acts against your sticky food, which generates pull forces onto the denture, right? You have to understand that the farther the fulcrum line from the point of application of force, lesser will be the rotation of the denture. So more terminal abutments you have, the rotation is going to be further less. That is why you require an additional rest and additional support in the area by using a secondary abutment, right? Now, what are the basic principles of a fulcrum line and indirect retention? The first factor which is important is the effectiveness of a direct retainer. The next one is distance from fulcrum line, right? So effective direct retainer. So if you have a good direct retention from your infrabulge or suprabulge clasps, you are definitely going to have a good indirect retention. And distance that we already discussed, indirect retention increases with the increase in distance between the fulcrum line and the point of application of force, right? That is why you have a couple of rules which we follow, like you have to place the indirect retainer as anteriorly as possible, right? That is where you use your canine rests and incisal rests, which act as your auxiliary rests in providing the indirect retention. You place the indirect retainer perpendicular to the midpoint of fulcrum lines, right? The next most important rule is that the connectors which support the indirect retention or indirect retainers have to be rigid connectors. There are no flexible connectors when you talk about indirect retention, right? Do not place indirect retainers on weak teeth. No, you cannot place them on weak teeth because they are supposed to provide you indirect retention. Do not place these rests on the inclines. They have to have a stable stop. That is why you do not place them on the inclines. Now, different types of indirect retention we already discussed. You have an auxiliary occlusal rest. You have your canine extensions. You have your canine rests and Lingua Plate. So these are the most commonly used indirect retainers. Now, what is basically the lever principle which we usually follow? So you have to understand that there are three types of lever: type 1, type 2 and type 3. Then we'll discuss how do we apply this onto the removable partial denture. So when you talk about type 1 lever principle, the concept is LFE. In type 2 you have FLE and type 3 is FEL, right? Wherein you know that this is your load, this is your fulcrum area force or the effort, right? For example, a very simple example I'll give you for a type 3 lever, which is your tweezer, which we very commonly use. So when you see a tweezer, how a tweezer is made is something like this, where here you have the material, which is the load, this area is the effort, and here is the fulcrum area, right? So that is what you need to understand the concept of levers. We are going to use type 1, type 2, type 3 levers in different indications of your removable partial denture. But to remember, you must remember LFE, FLE and FEL. This is how you are going to have your type 1 to type 3 levers which are going to be used. Now, this type 1 lever is used in your distal extension RPDs, right? The direct retainer is going to act as your fulcrum, right? When you talk about your distal extension RPDs, type 1 lever, the RPD teeth, the teeth which are on the RPD are going to be the effort. And the anterior end of major connector is going to act as your load, right? So this is what you need to understand in a type 1 lever application in removable partial dentures. is in the distal extension RPDs, where the fulcrum is the direct retainer, teeth are the effort for obvious reasons, and anterior end of the major connector is going to act as your load. That is why if you add one extra rest, this is going to shift the fulcrum anteriorly, right? One extra rest in the anterior zone, it is going to shift the fulcrum, and thereby it is going to help in indirect retention. Where type 2 lever is involved, it is involved when the patient is having sticky food. There is where your type 2 lever concept acts. The pull force of the sticky food is going to be your effort, and the anterior part of your major connector is going to be the fulcrum, whereas the intermediate zone of RPD is going to be your load, because that is the area where that pull force is going to get generated, right? So this is what you need to understand. Type 3 lever is not involved in removable partial denture, right? Now, how do you understand a fulcrum line, right? How many fulcrum lines do we have? That is what we need to understand, because a lot of questions come up on the fulcrum lines. So talking about a Kennedy class 1 situation, this is how you have a Kennedy class 1 situation. This is the arch, you have the anterior teeth present, and the bilateral posterior edentulous area. So talking about the first line, it is going to cross both the terminal abutments. So this is one fulcrum line. The other fulcrum line is going to cross the midline of the arch, the second fulcrum line. The third fulcrum line is going to be somewhere contacting the one side of the teeth. So the first vertical line is a horizontal line between both the primary abutments. The second line, which I have put in here, this second line is called as the sagittal fulcrum line. And the third one on the midline of the arch is your vertical fulcrum line, right? So this is what you need to understand about these different fulcrum lines and the indirect retention. Surveying is a very important topic. The first important question which comes from surveying is, who introduced a surveyor? Surveyor was introduced by A.J. Fortunati in 1918. Very important question. Multiple times this has been asked. Why do you want a surveyor, right? What do you do with a surveyor? Surveyor is related to the HOC, which is the height of contour, right? So you must know the height of contour of the tooth, because the area below the height of contour is going to be your retentive area. So you must identify in which tooth, which area is the height of contour, and whether I have sufficient amount of undercut present below the height of contour, which can be used for your retentive clasp assemblies. Now this surveyor is the first step while designing a removable partial denture. A surveyor consists of a lot of parts, where you have a surveying table, you have a vertical arm, you have something which is like this, a surveying table. This is the floor, or you can call as the stand. You have your arm here, which is the vertical arm, and then you have a suspended area here with a marker where you will be using your surveying tools. What are my surveying tools? I have an undercut gauge, right, to measure the amount of undercut. I also have pencil markers, or called as carbon marker, which is going to mark the height of contour. I have an analyzing rod, right, and I have a wax knife. Why do I have a wax knife here? Once I'm done with the wax up, I'm going to place my model here, remove the excess wax using the wax knife to create the specific amount of undercut which I'm looking at, right? So these are 4 important tools which are used with your surveyor, right? So this is what we need to know. Another question which comes are the different variations or the types. So 3 main types are important for you to memorize: the Ney surveyor, Jelenko surveyor, and Williams surveyor. Ney has got a locking device where you can put the analyzing rod, you put the wax knife, and you can lock it. Jelenko is spring loaded, so according to the spring you can push it in, pull it out, spring loaded. And Williams is the most flexible surveyor. So these 3 surveyors are usually asked in questions: the Ney, Jelenko, and the Williams surveyor. Now, what are the different types of survey lines? right? You have 4 types of survey lines: high, medium, low, and diagonal, right? Which, how do you identify that? Now, when you do your surveying procedure, you have to understand that when you talk about a tooth, this is how the tooth is. This is the edentulous area. You have an adjacent tooth here. Now, we are talking about this tooth, right, which is the primary abutment. When you split the tooth in half, this area is called as NZ, the near zone, and this is FZ, the far zone. Near zone is that zone of the tooth which is present very close or adjacent to the edentulous area, right? So when you talk about a high survey line, in a high survey line, the contact or the presence of height of contour is in the occlusal third of the tooth, both in the near zone and the far zone, right? It is an occlusal third. When you talk about medium, you have occlusal third in the near zone and mid third in the far zone. Similarly, when you talk about low, you have the low line means cervical third of near zone and far zone. This is the low line. And when you talk about the diagonal line, you have occlusal third of near zone to cervical third of far zone. Right? So this is what you need to understand. So when you have a high survey line, that means you have deep undercuts. You have deep undercuts, you use a wrought wire clasp. Medium survey line, you can use any of your Suprabulge or Infrabulge clasps. When you have a low survey line, you cannot use a Suprabulge clasp. You will have to use an Infrabulge clasp. When you have a diagonal survey line, it is going to be your reverse circulate clasp or a T-clasp or a ring type clasp. So this is what you get defined when you do your surveying. So surveyor will determine which kind of a direct retainer has to be placed in that area, right? That is important, all the importance of your surveyor and the survey lines. Coming on to another important topic, which is called as impression procedures in a removable partial denture. Now, a removable partial denture impression is very different from a FPD impression or a complete denture impression, because here you need to record the tooth in its anatomical form, right? You have to record the tooth in anatomical form and the tissue in its functional form, right? You cannot record both in anatomic form because the tissue is going to get displaced. That is what we read in the first session, that the tooth is going to get displaced very less than 100 microns, whereas the tissue is going to get displaced depending upon the type of tissue from 1 millimeters up to 2.5 millimeters. So that is why you require special impression procedures when you talk about a removable partial denture. These kind of impressions are called as dual impression procedures. Dual impression procedures, you have 2 options. One is called as an altered cast technique, which was given by Applegate. And the other one is a pickup impression, which you are all used to. You have done it also. So this pickup impression further has McLean type, Hindle's modification to the McLean method. You have a functional reline method and a fluid wax technique. Right? These are all different types of the dual impression procedures. So what do you basically do in a dual impression? I will just give you a small brief of how a dual impression procedure is done. You make a custom tray for the edentulous part, right? Not for the dentulous area, only for the distal extension edentulous area. You make your occlusal rims on that. That is going to be used for your closed mouth technique to apply physiological pressure so that you can record the tissues in their functional state. Load your zinc oxide eugenol and ask the patient to bite. Most important step now, do not remove the tray from the patient's mouth. Let that tray be there in the patient's mouth, and over this you pick this custom tray with an alginate loaded normal stock tray. So when you remove this tray with the alginate, both the trays come out together. right? Why they come out together? Because the first one has got your custom tray inside. You place your alginate loaded tray, and when you pull it out, the custom tray also comes out. So this is called as a pick up impression. Now there were a bit, disadvantages of McLean technique. The major ones being that the finger pressure which I have applied cannot be controlled, right? You cannot control the finger pressure. So it is not necessary that that pressure is going to be a functional pressure. It is going to give a functional movement to the tissue. So that is what you need to understand here. Secondly, you will have alginate in between your occlusal rim and tray, and that alginate is going to take up some area, thereby distorting the impression. That is why Hindle gave a small modification. So what Hindle said, that when you are making this impression tray, your normal tray is like this, and when you make a special tray for your approach to the distal extension for pickup impression, leave 2 holes in this area. Why? Because this is now going to apply direct pressure, and there is going to be no alginate which is going to fill in this area. You can directly apply a functional pressure over the holes so that you directly come in contact with the occlusal rims, right? Now, what are the problems with these methods? So when you follow these methods, the McLean or the Hindle method, the problem is that the tissue will always be in a compressed state. That means if I give my removable denture after these impressions, the tissue is always under stress, the tissue is always under pressure. So when the tissue is always under pressure, it is going to lead to bone loss, frequent requirement of relining and rebasing, which has to be taken care of. That is why the other method came up, which is called as the altered cast technique, in which you have to cut the model, you have to cut the cast from the edentulous area, make the impression of the edentulous area. If this is the situation, right, and you have the anterior teeth present, so you must cut your cast like this so that this part is preserved. Just make a custom tray and impression of this area, reattach it here, and then pour, right? So that is what is called as altered cast. You are not making a new impression, you are just altering the original impression cast, which is called as the altered cast technique. Another important thing before we wind up the removable partial denture is the color coding, right? A lot of time this question has been asked, color coding in removable partial denture when you do your designing, right? So you have brown color for the metallic parts, you have your blue color where an acrylic resin will be present. Next is your red, is all for your mouth preparation, where you want to place your guiding planes, you want to place your rests, right? All these things come under the red color. And the black is going to be your carbon marking, which is majorly for the survey lines, the hard and soft tissue undercuts, right? So this is what you need to remember, the color coding. Frequently asked question, heel raising in RPD. What is heel raising in RPD? The posterior segment of the RPD will always tend to lift up on application of force, right? So this is called as heel raising. As soon as the forces are applied, the posterior segment tends to lift up. This is an antero-posterior rotation which is happening in the denture, which is called as a heel raising movement, right? So antero-posterior usually happens in the posterior segment. Now there is something which is called as secondary retention. Secondary retention is not direct retention, is not indirect retention. Secondary retention in a removable partial denture is by the polished surface of the denture, right? This is what is called as secondary retention. Secondary retention can also be achieved by maximizing the tissue coverage, right? By when you maximize the tissue coverage, you get secondary retention. So that is why it is very important that you have intimate contact between your RPDs and the tissue. Basically, the major connector and the tissue should have intimate contact. Only then you will have a secondary retention which comes up. right? So that is most of the part of a removable partial denture, which is important from your exam point of view. So what we need to understand here is that this is not in complete detail. You will have to refer to the original lectures to get into detail, but all the concepts I have tried to cover up in this session so that there are no questions in removable partial denture which you miss, and you definitely need to revise these concepts, learn the numbers, understand the undercuts and the clasps, revise it properly before you leave for your exam, right? So this is all about the removable partial denture. So we are going to talk about articulators. So what you need to understand at the outset is that in the condyle, when you have the condyle moving into the glenoid fossa, it is moving in the S-shaped curve. But in an articulator, you have a straight line path, right? That is why an articulator cannot simulate the entire, the condyle and glenoid fossa relationship in a 100% accurate manner. Now, coming on to the classification of articulators, you get a lot of questions from that. Based on the theories of occlusion, you have Bonville theory, conical theory, and spherical theory, right? So spherical was given by Monson. Conical is an example of Hall articulator. With Bonville, you have the Bonville's triangular theory, wherein you have 4 inches as one of the sides, each side of your Bonville triangle, right? When you talk about the conical theory, they say that it moves as if it is at an angle of 45 degrees, right? The cone is at an angle of 45 degrees. Now, this is one of the most basic classification of articulators. Coming on to the type of records, what kind of records can this articulator accept? You have articulators with interocclusal records and you have graphic records, right? Following this, you have the classification based on the ability to simulate movements. Very, very important classification. Class 1, only vertical movement is possible, right? The examples are your slab articulators, barn, door, hinge articulators. They come under class 1. The class 2 articulators have both horizontal and vertical, but they do not accept your Facebook transfer, right? Like your mean value articulators, Monson articulator, Hall articulator, House articulators, right? The type 3 or the class 3 is horizontal and vertical, plus it also accepts your Facebook transfers, right? You have an example of Hanau H2, Bergstrom articulator, Panadent articulator, True Bite articulator. All these come under the category of class 3. And class 4 are those articulators which accept 3D registrations, right? All the 3 dimensions can be recorded in a class 4 articulator like TMJ articulator or Stuart Nathoscope, right? So these are the articulators class 4 most commonly used in full mouth cases. Then you have articulators based on adjustability, right? They are your non-adjustable articulators, semi-adjustable articulators, and fully adjustable articulators. Non-adjustable are the ones which we use, like you have your hinge articulator, mean value articulators. Semi, you have your Hanau and Whip-Mix articulator. And fully adjustable, you have Stuart articulator or Granger simulator, right? Now, the semi-adjustable articulators can be again classified into an Archon type and a non-Archon type. Archon is the one which is same as your mouth. That means the condylar part will be in the lower member and the upper member will have the articulating fossa, right? A non-Archon is exactly the opposite of that. So majorly what you use is a non-Archon articulator. So you don't get a lot of questions from articulators, but most of them are pretty straightforward the way we have seen it here. Another important topic is your teeth selection, right? The questions majorly come in from dentogenic concept. Who gave this concept? Frush and Fisher. Do not confuse with Fish. Fish gave the concept of neutral zone, right? Do not get confused. So dentogenic concept is also called as SPA factor or SPA concept, wherein S stands for sex, personality, and age, right? So these are important criteria when you do your teeth selection. For the posteriors, you have to understand that you have cusp teeth, you have your cuspless teeth, and you have some special forms. So in the cusp teeth, you have anatomical teeth and semi-anatomical teeth. So anatomical teeth are 33 degrees, and also there is one category of 30 degrees called as PT teeth, Pilkington Turner tooth at 30 degrees. Semi-anatomic can be 20 degrees or 10 degrees. 10 degrees are called as anatoline teeth. Right? So this is the major classification when you talk about posterior teeth selection. Why 33 degree is considered as anatomic? Because 33 degrees is what you have, as your condylar guidance. Most commonly, the condylar guidance is 33 degrees. You will see an average of a lot of patients that comes down to 30 to 33 degrees. That is why the anatomic teeth range also ranges from 30 to 33 degrees. A very important question coming up from denture adhesives. What are denture adhesives? They are majorly formed by CMC, carboxyl methyl cellulose, right? What is the mode of action of a denture adhesive? It swells when it comes in contact with saliva or water. As soon as it comes in contact, it swells up and fills in the space between the denture base and the tissue. That is how a denture adhesive acts. A few important questions coming up from sequelae of denture wearing. Not a lot of questions come in from sequelae, but there are a few very typical questions. Denture stomatitis. They will give you cases. They will give you a case presentation as to how the patient approached after wearing the denture. They will give you a set of problems. With that set of problems, you need to diagnose what is the sequelae that the patient is suffering from. So denture stomatitis basically means sore mouth. So you have type 1, which is mainly trauma-induced. Type 2, which is erythematous and diffuse, right? Type 1 is pinpoint. Type 2 is diffused. And type 3 is granular, right? So type 3 is the dangerous one, which is the granular denture stomatitis. Just something similar to a denture stomatitis is called CADS, Candida associated denture stomatitis. You will find mycelia there. Angular cheilitis, commonly present in Candida cases. Angular cheilitis. Another important question comes up from Epulis fissuratum, right? This is also called as denture irritation hyperplasia, right? When you get this question, do not confuse it with denture stomatitis, right? This is denture irritation hyperplasia, mostly caused due to unstable dentures, right? Then you have something which is called as burning mouth syndrome. No visible change in appearance. That is the most classical feature, that the patient is going to complain you of burning mouth, majorly due to allergic reactions from the denture, or sometimes if the ridge is extremely resorbed, you have mental foramen lying on the crest of the ridge, you have pressure from the denture, and that is going to cause burning mouth syndrome, right? So these are a few important questions coming up from sequelae. There is one more thing which is called as inflammatory papillary hyperplasia, right? This is a benign lesion. Nodules are present around 2 millimeter size and mainly present in the location of hard palate, right? Next, we are going to talk about relining and rebasing, right? When you have to do relining and rebasing, when the denture has altered the tissue, or because of any systemic cause, the tissues have already got altered, like in cases of diabetes, etc., you will have to do relining and rebasing, right? Relining is done only when occlusion is perfect. There is no change in occlusion. If the occlusion is not perfect, you have to make a new denture. No relining or rebasing is done when the occlusion is not correct. If the occlusion is correct, only then you have to change the intaglio surface or the base of your denture. There is where you require relining. So relining is a smaller procedure. Mainly rebasing is the bigger procedure, wherein you change the entire base. In the reline, we are just going to line the the intaglio surface with a thin layer of your liners. Very important question. If both maxilla and mandible have to be relined, a lot of time these questions have come up. Both maxilla and mandible have to be relined. You always do maxilla first. Why? Because that maintains the occlusal plane, right? So always maxilla first when you're doing relining and or rebasing. So when we talk about the major relining procedures, you have to understand that they can be divided into clinical procedures and lab procedures. Talking about clinical procedures, you have static relining methods, you have functional relining methods, and you have chair side relining methods. Static, you will have open or closed mouth. Functional will always be a closed mouth technique. In the lab, you do it with articulator method or a jig method and flask method. So these three techniques are lab procedures of relining or rebasing. Boucher gave an open mouth technique. The functional technique was given by Winkler, right? What is a tissue conditioner? Talking about a tissue conditioner is a soft relining method material. They are basically used for intaglio surfaces, especially when your tissues are abused. You never reline your dentures, you never rebase your dentures if the tissues are abused. So the first step in treatment of an abused tissue is to discontinue wearing the dentures. Once the tissue abuse has ended, the tissue looks firm and healthy, only then you should reline your dentures. Now there have been questions like stripping method. What do you mean by stripping method? Stripping method is done for non-anatomic teeth. Please do not get confused. Stripping is done for non-anatomic teeth. What is used? We use carborundum paste. Carborundum paste is used for stripping, right? So that is how you do the adjustments with the non-anatomic teeth. So what you need to know is that if the question is talking about stripping method, then the answer is going to be carborundum paste, right? How do you immerse your denture? Denture immersion, what is the best best medium to immerse a denture? The best medium is chlorhexidine, diluted chlorhexidine. Other than that, sodium hypochlorite can also be used, right, for denture immersion. But mostly you will get a question wherein the answer is going to be chlorhexidine, which is diluted. Coming on to another important topic, the immediate dentures. Understanding the immediate dentures, they are usually made when the anterior teeth cannot be left, right? You cannot allow the patient to be without teeth. So what do you usually do? You first knock off all the posterior teeth, right? You do your extraction, and after that, record your bite, trial, everything is done. And then on the model, you remove the anterior teeth, right? Patient has got periodontal compromised dentition. You remove the posteriors first and do your bite and trial as if you're doing a removable partial denture. Place that into the articulator, remove all the anterior teeth which have been done in stone. Once you remove all the anterior teeth, what do you do next? You do your complete denture setup of teeth and acrylize it, right? Once you acrylize it, the entire set is ready. On the day of extraction, as soon as you do the extraction, place the denture in the patient's mouth. Most important thing, this denture should not be removed for at least 48 hours. Why? Because that is the time, if the patient removes the denture, the entire extraction sockets are going to swell up. Once they swell up, the patient will not be able to fit in the denture. So most commonly in the case of an immediate denture, the patient will come back to you and tell you after 3 days that the denture fitting has become really good and tight. Why? Because whatever slight amount of swelling was there, that has made a close contact between the tissue and the denture base, thereby rendering the denture more active and more retentive, right? So immediate dentures are basically indicated in these cases. But with an immediate denture, you will always need to fabricate a conventional final denture after the complete healing of the soft and hard tissue is completed, right? You get a lot of questions from overdentures. What do you mean by overdenture? An overdenture is a situation where you have a few teeth remaining in the mouth, plus these teeth are healthy periodontally, right? They're strong teeth, mostly canines, right? So you use canines on both the sides, and these canines are going to act as an overdenture abutment. So what is going to be the advantage of using an overdenture? Retention, of course, but the primary importance would be proprioception, right? Because your abutment teeth which are present have got periodontal ligament, and this periodontal ligament is going to give you a very good proprioception. So the main advantage is proprioception, and next is your retention. It helps in decreasing the bone resorption rate, right? So these are important uses of your maxillary or a mandibular overdenture, right? So that is the most of the important part in complete dentures. We will be talking about a few other things in implants and maxillofacial in the next video. So here we are going to talk about a few important points based on the different MCQs which have appeared in the past papers and are important and the controversial parts of it. So number one is about the lateral pterygoid muscle. So you need to know that when the left lateral pterygoid contracts, mandible moves right, and when the right lateral pterygoid contracts, the mandible moves towards left, right? So that means the mandible will move towards the paralyzed side, right? You must remember this, very important. You get a lot of questions here that what happens when the left lateral pterygoid is paralyzed. So whichever side is paralyzed, your mandible is going to move towards that. Shunting effect, a question asked a lot of times, shunting effect in complete dentures. Now this is caused because of tipped occlusal plane, right? So that means if the occlusal plane is lower in the molar area, what is going to happen? The upper denture is going to displace posteriorly and the lower denture is going to displace anteriorly, right? So that is what is called as shunting effect. A lot of times this question has been asked as doubts. Third thing is the difference between CID and IID. CID is the conventional immediate denture and IID is the interim immediate denture. In the interim immediate denture, all teeth are extracted on the day of denture insertion, right? And when you talk about CID is what we discussed in the immediate dentures. The posteriors are extracted first and then the anteriors on the day of denture insertion, right? So that is the difference between CID and IID, right? Coming on to the the resilient liners, you get questions from the resilient liners where you need to know that the silicone elastomers are more prone to fungus, right? Whereas the acrylics are good long-term liners and you can reline it very easily with the acrylic part. The tissue conditioners are all short-term, right? So the silicone elastomers and acrylic, which are plasticized acrylics, are long-term reliners and the tissue conditioners are short-term reliners. Then you very commonly get a question, what should be the position of the incisal pin, right, in a semi-adjustable articulator? So the incisal pin is always out of contact. Why is it out of contact? So that it does not interfere with the condylar guidance setup. That is why the incisal pin is always out of contact. Shadow effect. What is shadow effect? Shadow effect is the negative space, right? What is the negative space? So when I'm talking, when I'm speaking, you can see some amount of space between the upper and lower incisors. That is called as negative space. It is different from the buccal corridor, so do not get confused. Then you get a question on emergency retentive force. Now, emergency retentive force for a denture is invariably, the answer is atmospheric pressure and the value is 14.3 psi. But if you do not have atmospheric pressure in your options, the next best option is going to be base of tongue. If you do not have base of tongue also as an option, the next best answer is going to be posterior palatal seal area, right? What kind of teeth, right, when you have decreased interocclusal distance, right? When you have very low interocclusal distance, resin teeth, the acrylic resin teeth are contraindicated. Why? Because you will have to trim them a lot to seat them, to place them, and they lose their bulk. If the resin teeth do not have bulk, they are going to get fractured, right? That is why they are not used when you have decreased interocclusal distance. Talking about the posterior reference points, right? The most commonly used posterior reference point is the Kaiser point. Now, what are the different points and what do they mean? So Kaiser point is 13 millimeters in front of the most upper part of external auditory meatus on the line which is passing to outer canthus. Right? So this is the most important posterior reference point. Other than this, you have Bergstrom point, which is 10 millimeters anterior to the center of spherical insert for the external auditory meatus and 7 millimeters below the FH plane. The third most important point is the Bayron point, which is 13 millimeters anterior to the posterior margin of tragus on a line passing from center of tragus to the outer canthus. Right? So these are the three most important posterior reference points which you will come across very commonly. The next important thing is that when you talk about a fluid wax technique, so if it contacts the tissue, it appears glossy. No contact, it appears dull. But with green stick, it is exactly opposite. Right? So that is what you need to see in the question. If the question is asking you about fluid wax, when it contacts the tissue, it becomes glossy. When it does not contact, it becomes dull. But green stick, when it contacts the tissue, it becomes dull. And when it does not contact, it becomes glossy. Right? So that is what you need to remember. Do not confuse between fluid wax in the question or green stick in the question. Then you have a dual function muscle, very commonly asked question. Masseter is the muscle with dual function, wherein the first function is elevation and protrusion. The second function is that when the mandible is protruded and biting force is applied, right? At that time, the deep portion of this muscle stabilizes the condyle, right? That is the important reason for your dual function of masseter. Now, coming on to a few small points in your FPDs, you need to understand that when you talk about the shade matching part in the Vita shade guide, they are always arranged by value, right? The hue comes in the end. The sequence for hue is going to be A, B, C, and D, wherein A is the red-yellow hue, B is yellow, C is gray, and D is red, yellow, gray. Right? So you must remember the hue sequence, but the shade is matched with starting with value, right? So it starts with B1, A1, B2, and the last goes as A4, C4. Read this entire sequence because it is important when it comes in your exam. Pkt Instruments, they are given by Peter K. Thomas. All these instruments are used for making wax pattern, wherein the Pkt 1 and 2 are the wax addition instruments. Pkt 3 is the burnisher, and Pkt 4 and 5 are your wax carvers, right? Do not get confused between the different Pkts. In Rpd, you need to know the color coding for your Rpd designing, right? This is a very important part. So the brown color is the metallic component of the Rpd. Blue is for acrylic. Red is for rests or mouth preparation. And black is for the survey lines, right? So this is how you design your removable partial denture. What is meant by heel raising movement? So heel raising denture. What is meant by heel raising movement? So heel raising movement is basically when the posterior segment of a distal extension RPD raises on force application, right? So this basically means an antero-posterior rotation which is away from the tissues, right? So this is the important part which we need to understand. A few important relevant questions which come up, and there are a lot of doubts because these you have answers in different books given in different some are correct, some are the old edition answers which have now changed. So this was most of the important points which I wanted to convey. So with this we end the LMRP session, and all the best for your exams.